Hi all, welcome to the respiratory system discussion on the OPD. So here we will first discuss in detail about the history taking and what examination features to expect in different diseases. All right. Then we will discuss about the symptomatology, in which in respiratory we have two main symptoms, as you all know. Right. So one is dyspnea, in which we'll obviously see the orthopnea, PND, all the red flag signs in the dyspnea. Then we'll discuss about the cough, where we will discuss how to manage dry cough, wet cough, what are the causes of acute, subacute, chronic cough. All right. Then we will discuss bronchial asthma. As you know, it's very common either in OPD as well as in the emergency in the form of exacerbation. Then fourth is COPD. All right. Fifth, we'll try to shed some light on the pneumonias, like how to manage pneumonia with the help of curve formula. When they give antibiotics, what are the regimes we use? All right. Then we will discuss about the pulmonary artery hypertension in short. All right. Also about the ILDs and the occupational lung diseases, including hypersensitivity pneumonitis. Okay. So yes. Now let's start with this examination part in the RS, like what to expect. So first of all, we have this question. Let's approach this question. Okay. So we have a 45-year-old non-smoker presents with dry cough. It is progressive with the progressive dyspnea for 3 months. So it's probably a chronic cough, right? More than 3 months he's having. All right. So around 8 weeks, we say the cough is acute or subacute. So less than 4 weeks, we say it's acute. 4 to 8, we say it's subacute. More than 8 weeks, we say it's chronic. So this has to be a chronic dry cough with progressive dyspnea. Respiratory rate is 22 per minute. So that's good. Means like not tachypnea. On examination, we get clubbing, bilateral basal end, inspiratory crackles, normal percussion, reduced chest expansion. That means there must be some underlying restrictive disease in this case. And the clubbing suggests that this not has to be with the COPD, right? Because COPD will not have clubbing. Why? Because although COPD is mainly leading to hypoxia, it doesn't damage your pulmonary structure or pulmonary vasculature. And pulmonary vasculature, whenever it is damaged in any pathology, either it is ILD, either it is malignancy like bronchogenic carcinoma or non-small small cell carcinoma of the lung. In these cases, when the vessels are damaged, they produce what? So they produce VEGF, that is vascular endothelial growth factor, and this VEGF at your nail beds give rise to the clubbing. But this is not the thing in case of COPD. Why? So COPD will only cause hypoxia, and there are no structural damage in the lungs per se. No structural damage in case of lungs. That's why we don't see clubbing with the COPD. So COPD is ruled out. Bronchiectasis is ruled out because bronchiectasis is wet cough, right? Here the patient is having dry cough. So what are the causes of the dry cough? So dry cough is mainly seen in the asthma. So asthma has two variants. Okay, so dry cough variant of the allergic type of asthma. Okay, also in case of early part of interstitial lung disease, or in the majority of the interstitial lung disease, you can have dry cough. And also in case of viral infections or upper respiratory tract infections, you can get dry cough. Now, considering patient's chronic cough history over here, we can identify that bronchiectasis is also not the cause and asthma is also not the cause, considering the end expiratory crackles. If they have given the wrong chi, if they had given the wrong chi or wheeze in the examination part, yeah, right? You guys know that during asthma. So suppose this is a normal airway, and in case of asthma, there will be airway narrowing like this. So whenever the air passes through this, obviously a whistling sound will produce. That's what we call as a rhonchi when we hear from the stethoscope. But if you listen it, without stethoscope, then you can say that patient is having asthma. But here, obviously, in case of severe asthma, you will have silent chest. But they've already mentioned the end inspiratory crackles, so that gives overall clue to the diagnosis of interstitial lung disease. So that's how you should approach a question or case whenever you're seeing any of the history of chronic cough. Now, with the help of this, we will see what are the important features which we see in the examination of all the respiratory cases. So let's go ahead. So, as I said, that clubbing plus Velcro crackles suggest ILD. No wheeze, no productive cough, COPD and bronchiectasis are unlikely. Asthma is episodic and not progressive with the clubbing. Okay, so there will be episodic asthma, but here in this patient, the cough or dyspnea was progressive. Okay, unlike asthma. Okay, so let's see now. So breathlessness, acute or chronic. So whenever you see the patient with breathlessness, you should ask yourself that this is acute breathlessness or chronic breathlessness, or does patient have orthopnea, or is there in positional breathlessness? So what are the causes of the acute breathlessness? So acute breathlessness will be seen whenever there is a sudden damage to the lung parenchyma or sudden damage to the pulmonary vasculature, like in the form of pulmonary embolism where the vasculature is damaged, or the parenchyma is damaged in case of pneumothorax. Okay, spontaneous or tension pneumothorax. Okay, pneumothorax. Okay, so these are mostly you see in the acute cough. Okay, apart from this, in case of or in the acute exacerbation of bronchial asthma or acute exacerbation of COPD or even acute exacerbation of the ILD. Okay, so this can be causes of the acute breathlessness. I hope you got it right. So pulmonary embolism, pneumothorax, acute exacerbation of bronchial asthma, COPD, and ILD. Okay, whereas chronic cough. So chronic cough can be seen in case of your chronic breathlessness. I'm sorry. So chronic breathlessness will be seen mostly in patients whenever there is a parenchymal disease of the progressive or chronic pathology. So interstitial lung disease, COPD. Okay, overall your asthma component. Okay, then any parenchymal disorders in the form of your occupational lung disease. Okay, so these are the causes of the chronic cough. Also, you can say in the malignancy as well, you can see chronic cough, chronic breathlessness. Now talking about the cough. So cough, whenever you have the history of cough, again you have to ask yourself that it's a dry or productive cough. So we know, or diurnal or nocturnal. Okay, so and or is it early morning? So early morning is in COPD. Okay, so let's first of all see it's dry or wet. How do we or productive? How we define the causes. So in case of dry, asthma is the very important cause. As I mentioned, allergic type of asthmas. Okay, also ILDs, also viral diseases. Okay, early viral infections can have dry cough. Now talking about the productive, so very important cause for this is bronchiectasis. Okay, bronchiectasis, COPD, particularly chronic bronchitis component of the COPD, and the pneumonias, right? And the pneumonias. It's very, very important. These are the causes of the productive cough. All right. Now coming to the sputum. So whenever we have different color of the sputum, right? So if it's a yellowish, obviously it's a purulent sputum. It's a infected, so it has to be pneumonia. Okay. So if it's purulent, that means yellowish, then it's a pneumonia. Okay. If it has a red currant jelly on that, it's a Klebsiella pneumonia. If it's a greenish in color, it's a Pseudomonas type of. But overall, if it's a purulent, the pneumonia is the underlying cause and you need antibiotics in these cases. Now, whenever it's a blood streak, so blood streak again can be in cases of pneumonia, okay, or I would say some pneumonias, you can see a blood streak, then viral pneumonias, you can see, okay. Then most important causes, if you ask me, is tuberculosis. In India, it's very, very common. Then malignancy. Okay. So these are the main causes where the bronchiectasis, very, very important. And the bronchiectasis. Okay. Purulent can also be in the COPD. Okay. And here is the bronchiectasis, very important cause. So these are some of the causes: pneumonia, viral, TB, malignancy, and the bronchiectasis. Okay. I hope you got it. Then talking about the wheeze. So wheeze, if it's reversible, seen in the asthma. If it's persistent, then it's in the COPD. Because the pathology itself in asthma, whenever you give the bronchodilator, there are reversible changes in the airway, right? Because if, as I told, in asthma, the airway will get narrowed like this. And whenever you do bronchodilator, the airway will again become like this. Okay, but in case of COPD, the overall size of the airway is down like this or not reduced like this. And instead, you give either anticholinergic or anything, it doesn't help because it's a irreversible phenomena. So COPD, you have persistent wheezing, and in case of asthma, you have reversible wheezing. What are the cardiac causes of wheezing? So this is a very, very important topic. So cardiac causes, you have the most important pulmonary edema. Okay, pulmonary edema or cardiac wheeze. Okay, pulmonary edema or the cardiac wheeze, because of the accumulation of the fluid in the interstitial spaces. Whenever the air is passing through the lungs, it will produce a musical sound like wheeze. I hope you understood this. So patient will have breathlessness, JVP will be raised. JVP will be raised. The legs will have edema, right? Sometimes ascites can also be there, and reduced urine output and all those features can be there. Okay, and the underlying history of the heart disease will also be there. So I hope you understood when to consider pulmonary causes, when to consider the cardiac causes. Now talking about the hemoptysis. So hemoptysis again, TB, carcinoma of lung, and mitral stenosis. These are the main causes. Hemoptysis means nothing but the fresh clotted blood in the sputum. Okay, and in this condition, you have to ask the amount also, because if there is a profuse hemoptysis, then you have to suspect either bronchiectasis or also can be in case of tuberculosis. Okay, and if it is fresh or clotted or mixed with the food, then if it's mixed with the fluid, then you can understand that it's not hemoptysis, it can be hematemesis. All right, so that's how you can understand the difference between hemoptysis and hematemesis, because it's very important to understand the difference. If it's hematemesis, then you definitely have to do the endoscopy, but only if it's hemoptysis, there are no food particles with it, there is no history of the abdomen pain or anything, just history of cough is there, then you have to consider it as a cause of the pulmonary origin. Okay, and then you don't necessarily warrant the involvement of the gastroenterologist for the endoscopy. Okay, right. Then coming to the occupational and environment is very important in case of respiratory system per se, because there are certain occupational diseases. For example, if person is involved in the mining, okay, so obviously there will be coal worker pneumoconiasis. If the person is involved in the construction, then there will be a silicosis associated with that, right? Or coal worker pneumoconiasis. So these are the form also called as occupational lung diseases. Okay, here also the lung parenchyma will be involved, and all these are included into the restrictive lung pathologies. Okay, restrictive and obstructive are two pathologies. I hope you know that. Okay, so obstructive means the airway is obstructed. And restrictive means the lungs expansion is restricted. Okay, so we will discuss this in detail when we discuss the pulmonary function test also. So don't worry about this. Then organic dust, like farmers, bird breeders. Here we have a very important disease, that is hypersensitivity pneumonitis. Okay, HSP. Hypersensitivity pneumonitis is upcoming disease, and in the cities like Mumbai, or wherever there are like more amount of the birds, then they are under a lot of exposure of these birds, even just like the bird handlers, because of lots of birds around them. So that can lead to the hypersensitivity pneumonitis, and the treatment is not there available. So probably lung transplant would be the only thing for these patients. So prevention is the cure for now. Okay. Then asbestos. So asbestos can cause asbestosis, and even asbestosis for a longer like days or longer years can itself give rise to malignancy. That's called as mesothelioma. Okay, even paints and fumes can cause occupational asthma, COPD, even smoking. Smoking itself is associated with the COPD and the lung carcinoma. Okay, COPD, carcinoma lung, and even chronic bronchitis. So, for if somebody is having smoking history, we should ask that for how many years he has been smoking to calculate this pack per year formula. So, if the pack per year or pack years of the person is more than 20, then definitely there is a significant COPD risk. You have to consider COPD, do spirometry, start treatment for the patient. Okay, so it's very important to understand the pack years, because that will give you an idea about the tar content of the person's lung. What is tar content? That means how much black the lung has got because of the smoke he has done to himself. So let's see how the pack years are calculated. So first is number of the cigarettes per day divided by cigarettes per day. Okay, this is itself divided by the 20 into years he has been smoking. Okay, so suppose somebody is smoking at least 10 cigarettes per day. Okay, so 10 per day, so it has to be 10 by 20. Okay, 1 by 2 into, for example, 40 years, so the score is 20. All right, so if the score is more than 20 pack years, there is a significant COPD risk. Okay, I hope you understood that. Okay, then BD has a higher tar content than the cigarettes. Okay, somebody is BD smoker, or somebody is like traditional cigarette smoker. Then when you get the higher amount of the tar, so it's more in the BD. Okay, that's even logical, right? Yes, but that doesn't mean that I'm promoting anything. All right, any type of the smoking, even vape, even the your digital vapes are also harmful. Okay, flavored vapes and all are available right now in the market, right? Oh, okay. Coming to the general examination, it's very important in case of RS, gives you all the clues about your patient. Either you're talking about the respiratory rate. So suppose your patient is having tachypnea. So tachypnea tells that patient is under the respiratory distress. Okay, so it suggests the patient is in the respiratory distress, and we have to be little cautious, or we have to be little worried about the patient's condition. Whatever can be the cause, either asthma, acute exacerbation of the asthma, or acute exacerbation of the COPD. Okay, anything like that, or even in pneumothorax or any pleural effusion. Okay, or if patient has any other cardiac condition in the form of pulmonary edema. So you have to be little worried about the respiratory rate. Make sure you know how to calculate it correctly. So suppose if patient is lying down like this, okay, you just watch for the movement of the abdomen of the person. Okay, so you just watch while taking the history of the person without making person conscious, because if you're conscious, the respiratory rate will get suppressed. All right, so unconsciously, just when patient is talking to you, just try to measure it for 10 seconds, and then you can multiply it. Okay, so that's whenever you're in a rush, but obviously ideally at least for 30 seconds you should measure, right? Then very important part along with the respirator you must do is to check the accessory muscle. Okay, so when you check the accessory muscle like sternocleidomastoid or intercostal muscles, okay, so sternocleidomastoid muscles, intercostal muscles are barely visible, but sternocleidomastoid, then your nasal alveoli, okay, so these are very important. Even trapezius rarely it's used, but yes, these are the muscles you should look at, that is person is having use of this muscle or not. So if there is use of these muscles, that means again he is under the distress, or particularly there is a air hunger, okay, giving rise to these features mostly seen in the COPD, okay, even in asthma, or even in respiratory distress, acute respiratory distress. Then pursely breathing. So pursely breathing is basically a very important tactic of your lungs to maintain the PEP. Okay, so to give the PEP, that is peak end expiratory positive pressure. Okay, so give that PEP to the lung. Your lips actually open like a purse. Okay, so with you must have seen this in the COPD patient. So they will breathe like this. Okay, so with the help of this, they will give a good amount of the pressure for the lungs to stay, to prevent the compliance of the lungs. Okay, I hope you understood. So this pursely breathing is very classical for the COPD patients again. Then barrel chest, again seen in COPD. When it is called as barrel chest, so normally your AP diameter, okay, AP diameter is slightly less than the transverse diameter, but if your transverse diameter and the AP diameter becomes same, okay, so first this is your lungs, this is your chest cavity, okay, normally the transverse is more AP, this is AP diameter, so suppose this is anterior, this is posterior, this is right, and this is left, so that means this is your AP diameter. So AP diameter normally is less than the transverse, but if AP and transverse becomes the same, so how will the chest look? Chest will look like this, right? So this is called as barrel chest, okay, where AP and transverse are almost same. So it occurs again in the COPD patients, okay, right? Then clubbing. So clubbing, I already told, bulbous nils occurs because of the increase in the vascular endothelial growth factors. There are different theories. Even some people say platelet derived growth factor, some people say hypoxia related. Okay, but moreover, accepted therapy is VGF therapy, okay, or growth factor therapy. So here you will get the bulbous nails, and the indications or causes will be ILD, carcinoma of lung, bronchiectasis, tuberculosis. Okay, so you should also know what are the cardiac causes of the clubbing. For example, heart failure, infective endocarditis. Okay, and you should also know what are the non-cardiac, non-pulmonary causes of clubbing. So what are those? So GI causes, and like in case of inflammatory bowel disease, like in case of biliary cirrhosis. Okay, so these are some of the causes of the clubbing that you should be aware of. Now talking about the cyanosis. So cyanosis is easy to understand whenever you have the hypoxia, either in the form of cyanotic congenital heart disease, COPD, ILD. So you can have cyanosis of two forms, that is peripheral or central. Okay. So now coming to the systemic examination. So first of all, inspection. So whenever there will be tracheal deviation, okay, so that suggests the pulmonary pathology. So if your trachea is shifted towards the pathology, then this has to be the collapse. Okay, or if it is shifted to the opposite of the pathology, then it has to be either pneumothorax, pleural effusion. Okay, then that's the logic behind that. Or mediastinal shift can also be measured with the help of tracheal deviation. Okay, so let's not go into details of the examinations, because we have already made a different module on this. That's a clinical medicine course. So I recommend you, if you like to learn all the clinical methods in detail, please go on and learn from that. But right now here the approach is to see how to manage the patients in the OPD, right? So then we have in inspection we see for tracheal deviation, scar, chest symmetry, paroxysmal involvement or movement. Then it suggests the diagnosis like fibrosis. If there is a tracheal deviation, mediastinal shift towards the side, that's a fibrosis. If it's to the opposite side, that's a pneumothorax. Okay. Or if there is a old surgery, you can see the scars. Okay. Coming to the palpation. So in palpation, you will get the tracheal position. If it's a central, again, you can confirm that fine with the help of trail sign. That means wherever there is a tracheal shift, there is a enlargement of the sternocleidomastoids clavicular head that suggests your sign. Okay. So here we can also see the chest expansion, vocal fremitus in the palpation, right? So if it is reduced, if chest expansion is reduced, that can be seen in fibrosis or pleural effusion. Okay. Then percussion. So percussion normally over the lung, you can get the resonant note. If you're getting it as a dull note, that means it's consolidation. Okay. And if you're getting stony dull, that means it's a pleural effusion. Okay. So what's dull note? Dull note means basically whenever you are applying the pressure, you will not get any sound. Okay. There will be a dull sound. And if you're getting pain over the flexor aspect, okay, this is flexor, this is flexor, then that's called as your stony dull note, typically seen in case of pleural effusion. I hope you understood. Then auscultation. So auscultation is easy to understand over here. So normally we have vesicular sounds all over the lungs, okay, except on the large airways like trachea and the primary bronchus. So, but in case of consolidation or in case of other pathologies, for example, this is the normal airway, this is normal trachea. Okay, till over here we have the your normal bronchial sounds, and if this is the lungs, if these are the lungs, you will have the normal vesicular sounds in the lung aspect. This is the line marking. Here you will get the vesicular breath sounds. Here the cross one. Here you will get the normally bronchial. But what happens whenever there is a consolidation over here? Okay, there is a consolidation. That means there is a solidification of the lung. What happens? The airway that is coming to this consolidation. So what they have a very solid surface over here. So from here the sounds gets reflected. All right, the sounds are getting reflected from here. Therefore, the intensity of the sounds will increase. So that gives rise to bronchial breath sounds. Okay, so now tell me, what are the cause for the bronchial breath sounds? Obviously, the consolidation. Okay, so consolidation is a cause of bronchial breath sounds. Okay, these are your vesicular and bronchial breath sounds. But the pathological bronchial breath sound. Now, let's see what are the adventitious breath sounds. So, adventitious breath sounds, you have the creps or crackles. Okay. Okay. So, typically, if it's end inspiratory crackles, that has to be ILD. Okay. And it's end expiratory crackles, then it has to be either COPD or in case of pneumonias. Okay. So, but overall, you can say ILD, pneumonia, okay, or also in the fluid overload. Okay. Then you have the rhonchi. So rhonchi we already discussed. Whenever there's a bronchospasm, like in case of bronchial asthma, allergies, COPD. Okay, so in such cases you will get the rhonchi, and if the rhonchi are audible without stress, then you can say that's a wheeze. Okay, you can say that's a wheeze. Okay, so these are the auscultation features. Even you can get the pleural rub also whenever there is a pleural effusion or dry pleurisy in the early part of the pleural effusion. Okay, so I hope you understood this. So now we have some unmissable points in the respiratory system in the OPD or during the history exam. So whenever there is a nocturnal cough, definitely you have to confirm that patient has a signs of heart failure or not. Okay, so it's very important to rule out that. Why the clubbing is not seen in typical COPD? I've already told you that, because it doesn't affect the pulmonary vasculature. Then weight loss plus hemoptysis, what to expect? Obviously tuberculosis and the carcinoma or carcinoma. Then Velcro crackles at bases has to be ILD. Okay, that mostly seen in the ILD. Then post-nasal drip and GRD. So these are two conditions. Whenever you will have the sensation of the something mucus in your oral cavity, or you will feel cough, that something is obstructing your airways with that mucus, and that's called as your post-nasal drip. Okay, it occurs typically when you go to sleep after 3 to 4 hours. Talking about the GRD, so it's typical your gastroesophageal reflux. This you will feel the gastric content in your mouth, and that again will give the bad breath or halitosis. So that's your GRD. Then peak flow measurement in asthma suspected case can be done, okay, in OPD also, like your spirometry. Then occupational exposure can give, must be asked in non-smokers who are having lung disease, okay, interstitial lung disease. Then never ignore clubbing in any RS case. Very, very important, huh? This point, because the end point is very bad. Either it could be a TB or malignancy. So never ignore a clubbing in the respiratory patients, right? So here we have some pearls. If bilateral wheeze improves with bronchodilator, obviously asthma will be the cause because it's a reversible. We discussed that. If clubbing, co-scriptation, large sputum volume is there, then it has to be bronchostasis. We have already discussed this too. Then always document respiratory rate. Please make sure in the history whenever you're checking the patient, always write respiratory rate, chest expansion, and the breath sounds. Just don't write RR. RR 40, patient is stable. Okay, make sure you document very well, because either if you are medically sued or anything, your documentation, if it's good enough, you know any law will save. But if it's not good enough documentation, they will tell you that did you check for the breath sounds. Obviously we do check for the breath sounds, but we never mention it. We just write that RS is not normal or NAD. Then chest expansion, we never check in OPD probably. Okay, so make sure this is medically very relevant. So whenever you are writing any history or writing any examination aspects or findings in your cases, make sure you write all of this in detail. Okay, then talking about the chronic cough, normal X-ray, always think about asthma. GRD, ACE inhibitors are the side effects. Okay, then in ILD, basal crackles may be present even when the chest X-ray is normal. Okay, obviously in the early phase, because of the just basis involvement, this CT will have some features, subpleural involvement, but here in case of X-ray you might not see some features. Okay, so make sure basal crackles, you just rule out ILD also. Okay, now let's see the pulmonary function test. Okay, so in pulmonary function test there are few things that you should remember. First of all, tidal volume of the lung. So what is tidal volume of the lung? The normal breathing of the lung. Okay, normal breathing, that means inspiration, expiration without any excess force. Okay, so inspiratory reserve volume, the reserved volume of the air after the normal inspiration or expiration of the person. Okay, normal expiration, whatever the air is in the lung, that's your inspiratory reserve volume. Similarly, expiratory reserve volume, whatever air is left out in the lung even after expiration, forceful expiration. Okay, respiratory volume is the same thing. That means even after forceful expiration. Okay, whatever or basal volume of the air that's in the lung, that's called as your residual volume. Okay, so what happens in case of COPD or the asthma, the overall component of this residual volume ARV increases, giving to the rise of air trapping, because there is obstruction to the airflow, right? So because of that, you will get the normal FEV1 by FVC ratio, forced vital capacity. We'll discuss that. No worries about that. Okay. So this is your inspiratory reserve volume. This is tidal volume. This is functional residual capacity, and this is your vital capacity. Okay. That means everything apart from the residual volume, that how much air is in the lungs, irrespective of what is the basal volume of the air. That's your vital capacity, and the total lung capacity is the amount of the total air of the lung that we can see. Okay. So based on that, we have different diseases now in the pulmonary function test. So if we have FEV1, that is forced expiratory volume in 1 second. That means in the first second, how much you can expire. Okay, that's your forced vital capacity. Forced expiratory volume, FEV1. That will give us a clue that do we have any obstruction in the airway or not. So if it is more than 80% of the predicted, that's normal. But if it is less than 80% of the predicted, then patient may have airway obstruction. So what is the most common cause for that? That's asthma. Okay, so I hope you understood. If you check for the FEV1, okay, suppose this is the graph. This is the graph. This is the graph. Okay, so this is your FEV1. That means in 1 second, how much air you are able to exhale. Okay, that's your FEV1. Okay, so as I said, it is decreased, FEV1 is decreased in obstruction and restriction. Then it can be increased in case of mild asthma, and interpretation is reduced in case of airway disease. That's like asthma. Okay, so it can be normal in mild asthma but never increase. Then talking about the forced vital capacity. So forced vital capacity will be high, normally more than 80% of the lungs capacity, forced vital capacity. And if there is a restriction or restrictive lung disease, this FVC, forced vital capacity, is reduced. Okay, so this is your FVC. Okay, so this is your vital capacity. This will be reduced whenever there is a restriction of the lung disease, because the air that's coming to the lung will also be reduced. Okay, so that's your restrictive lung disease, FVC will be low. Okay, so it can be high or normal in case of air trapping in COPD. Okay, that's your forced vital capacity, and it is reduced in case of restrictive lung disease. Like restrictive means like interstitial lung disease. Okay, but in case of COPD asthma, it can be high. Okay, so FEV1 by FVC ratio, that's what we were discussing about. Normally it has to be more than 0.7. It is reduced in case of obstructive airway disease. Okay, it is reduced in case of obstruction, normal or high in restriction. Okay, so in restrictive lung diseases, your FEV1 by FVC ratio will be high. Why? Because in case of your restriction lung diseases, your FVC will also be low, whereas your FEV1 can also be low. Okay, so because of this, your overall ratio can be normal to high. Okay, but in case of obstructive airway disease, your FEV1 is reduced significantly. Okay, so whenever FEV1 is reduced, your total ratio will also reduce. Okay. Yes. Coming to the total lung capacity, as you can see, normally it is 80 to 120% predicted. It is reduced in the restriction, increase in case of emphysema because of the air trapping, and it is gold standard suggestive of restriction. That is total lung capacity. And talking about the residual volume, again it is reduced in case of restrictive lung disease and increase in case of air trapping, in case of COPD emphysema. Talking about the DLCO, that is diffusing capacity of the carbon monoxide. Here it is normally more than 75%. It is reduced in ILD emphysema, very important. Okay, in ILD it is reduced and normal in case of asthma. Okay, so in case of clinical history also they can give you all these points telling about the pulmonary function test. Okay, so this is again the same thing that we just discussed, where the graphs can be seen. Okay, so graph, as we can see, this is the normal graph. Okay, expiratory flow and the inspiratory graph. Okay, so in case of obstructive airway disease, your FEV1 will be normal, but the overall curve will go down. Okay, whereas in case of restriction, your FVC itself gets low. Forced vital capacity itself will get very low, and because of this, there will be normal FEV1 by FVC ratio. Okay, in case of restrictive lung disease, the FEV1 by FVC ratio will be normal to increased. Whereas in case of obstructive airway disease, your FEV1 is already reduced. Okay, and FVC as such not changed much, but overall ratio will reduce. Okay, FEV1 by FVC ratio. That's the about the pulmonary function test. So with this, we will now start with the dyspnea in the next module. Thank you.